for dialing in this afternoon to our April policy briefing. For those of you who have joined our past monthly policy briefings, you know that we try to keep these pretty interactive. So I want to encourage you to turn on your video, unmute yourselves if you have a question. I'm very thrilled that we are joined this month by my colleague Alice Leiter, who is our Vice President and Senior Counsel. Got it right this time. And we are going to talk over a very timely issue, which is the HIPAA proposed rules. As you all probably know, there is a HIPAA proposed rule out right now, and Alice is going to go over some of the details of that proposed rule. Then we're going to open it up for a discussion where you can ask Alice some questions about her insights on the rule, future directions, and then we'll open it up for a general discussion around privacy in general. So with that, I will turn it over to Alice for her presentation. And as I mentioned, for those of you who just joined, we want this to be interactive, so feel free to turn on your videos and unmute yourself if you have questions, or if you prefer, type them in the chat box and I will ask Alice when we get to the end of the presentation. Okay, Alice.
Thank you, Catherine, and thanks all of you for joining us. This rule has been out now for about 4 months, so it may seem like it is old news, but also some people are just learning about it. There was a little bit of confusion given that it came out in December, right before the administration turned over, as to what would happen with it and would it stay even in place, but it is, and here we are. Comments are due pretty soon, so we thought we would just give a briefing of the major tenets of the rule and put it in a little bit of context. It's a long rule and there are a lot of details, so I cannot promise that I will know the answer to any specific regulatory language question, but feel free, of course, at any point to pipe up, or at the end of the half hour, if there's still questions that you have that are more specific, we can certainly follow up with you later. So Catherine, if you go to the next slide, this just sort of big picture. It was published finally in the Federal Register about a month after it was originally released on the 21st of January. And the comment deadline was originally this month, but got pushed back until May 6th. So we are still finalizing our comment letter. Happy to share that with you all when it's finished, or eager for any of your input for things that we should add. The point of the rule, the real focus is to both clarify some provisions of HIPAA as they are now and to amend others, really in an effort to facilitate the delivery of coordinated value-based care. That is, those are the buzzwords for this rule. And it's a big deal because there hasn't been a big HIPAA change really since the HITECH Act in 2009, which was part of the American Recovery and Reinvestment Act, ARA, better known as the Stimulus Act. And then again, to just provide some context, this is part of a big push that the Trump administration had, and we hope that the Biden administration has, really that recent administrations have had, to increase the flow of information from health systems into the hands of patients and their caregivers. The intent is to get individuals more engaged in their care, to remove some of the roadblocks that currently exist with respect to coordinated care. And there are a number of provisions in the rule that are really focused on reducing or eliminating, in some cases, the regulatory burdens on various components of the healthcare industry. And again, this is part of a number of coordinated efforts to increase information flow, increase interoperability. OCR, the Office for Civil Rights within HHS, issued a request for information a couple of years ago, signaling their intent to update the HIPAA privacy rule to make it easier to share information among all members of the care team. So that's traditional HIPAA covered entities like providers and payers, but also patients themselves and a broader array, especially in this rule, of caregivers. And then, of course, it was released in the time of the pandemic. And for those of us nerds like me, issues of privacy and public health and health information are always very important and top of mind. But the national focus was on information gathering, on information sharing to help stem the spread of the virus. And then, of course, there were concurrent privacy issues that arose with respect to all COVID efforts. Contact tracing apps were not particularly successful here due to privacy concerns. There have been privacy concerns on all elements of the COVID information gathering response. And so the context in which this rule dropped makes it particularly important, or at least noteworthy. And then there have also been two rules that came out of HHS, one from the Office of the National Coordinator for Health IT, and one from the Centers for Medicaid and Medicare Services, CMS, better known as the interoperability and information blocking rules. Those also long and detailed, but their big purpose and intent also is to remove barriers to information sharing and expand individual access to their to patients' own health data. Next slide. And the sort of final context thing I'll say here, before I came to EHI, I was a lawyer at Hogan Lovells in the health regulatory group, and spent a lot of my time trying to explain to people that HIPAA is actually a very permissive rule. It's often erroneously cited as being a barrier to disclosure. And very often you'll hear someone say, we can't do that because of HIPAA, we can't give you this because of HIPAA. And it actually is really a rule that is designed to facilitate and to safely promote the exchange of health information for care purposes. And I think that this rule is an effort to clarify some of those permissions, to expand the universe of people to whom information can be disclosed legally, and to really specify, clarify, while expanding the circumstances under which information can be shared and the people with whom information can be shared. Again, there's some modifications to expand the universe of people that are allowed to receive information without individual authorization. But some of the provisions in the proposed rule really are just clarifications. They're not necessarily changes. From a privacy standpoint, which is my personal policy interest, this rule has been pretty popular. There are a lot of really good things about it, and certainly it's hard to find any fault with the intent. The problem, of course, it's not really a problem, but it's just an issue, is that anytime the universe of people to whom information is given, or who have access to information, the privacy risks increase. And the more people that you allow to be part of this sort of HIPAA privacy rule tent, the more vulnerable the data gets. And of course, once information leaves a HIPAA covered entity or one of their business associates, it loses all HIPAA protection. The protections of HIPAA do not follow the data, they apply to the people that hold it. So we've been really involved at EHI and figuring out how, or thinking about how to close some of those gaps in legal protection for non-HIPAA covered health data. And this rule, again, it just expands the sort of, it makes information sharing easier and broader, and that's wonderful, but we're going to spend some time in our comment letter really talking about how that needs to be accompanied by some really specific privacy protections, and at least the awareness that data becomes more vulnerable the more attenuated it becomes from the HIPAA covered health system. With respect to the rule itself, there are several buckets of key provisions. The access ones are very important. The rule really aims to increase patient access to data and to clarify that HIPAA provides individuals access to their data. And to make it easier, the HHS has proposed shortening the covered entity's required response time to a request for information to 15 days. To make more, to strengthen and to make more clear an individual's right to inspect their records in person. These individual access has long been something in HIPAA that has been a little misunderstood and not particularly clear. Clarifying how covered entities should respond to requests for personal health information. specify when that information must be provided at no cost and being very clear about what the costs are. And then reducing the burden of verifying someone's identity when the request is made. Again, these are all things that get thrown around of we can't do that, it takes too long, it's too expensive. And the idea is really to make this patient right of access something that's meaningful and real to patients themselves, and to help the covered entities know what their obligations are, and then help them do it in an efficient and cost-effective way. Next slide. Disclosures too, again, under the HIPAA privacy rule, there are certain categories of disclosures that can be made without individual authorization. And there are some expansions to those categories of people and circumstances under which these unauthorized disclosures are now allowed. So the proposals are that disclosures can be made, again, without individual authorization when it's in the best interest of those that are experiencing a health emergency or a crisis. This also was driven a little bit by COVID on the public health front, but in a more individual front, mental health issues and substance abuse disorders were called out as circumstances under which disclosures of personal health information should be easier and more available options. Also to prevent harm or lessen the chance of it. Big category here is to enable care coordination. There are a number of provisions within HIPAA that are subject to the minimum necessary standard, which really means you can only disclose exactly the smallest amount of information possible to accomplish your care purpose. The care coordination exception here would expand the circumstances under which information can be shared and the people on the care team that can receive it. This concept of expanding care provided by social services and community service providers is a big deal. They have not traditionally always been thought of as members of the care team or members of the sort of HIPAA thought of provider association, but increasingly care is being delivered and sought in community-based organizations and in social service settings. And so this really expands the category of people who are considered part of the care team and thus authorized to receive personal health information.
Alice, are you taking questions as you go, or?
Sure.
Okay, great. So regarding the minimum necessary, I'm wondering if you can comment on how that pertains to clinical decision support offerings and the desire to pull in data that affords appropriate context for a given patient.
That's a great question. Comment on it, just how the minimum necessary standard applies to that. I don't know that off the top of my head, but if I remember correctly, there's not a, it is a standard that is subjective, of course, because what is the minimum necessary to accomplish a care goal? And clinical decision support tools are key to so many types of care. And I certainly know that they are contemplated within HIPAA. So I can't imagine that a key clinical decision support tool that requires certain information to do its job would be limited by the minimum necessary standard.
So I can tell you as a knowledge vendor that it is commonly used as an excuse for why we cannot get certain information. And I'm wondering if there's an opportunity to use the proposed rule to sort of emphasize the need that CDS vendors have for a lot of contextual information.
Yes.
I won't take any more of your time now.
No, not at all. I absolutely think there is. And I'm hoping Catherine is taking notes for me because it's a key point. You know, in some ways, clinical decision support tools are part of the care team, if you want to just think broadly. And so any opportunity to comment on something or any opportunity when there's a HHS ear, I would take it if I were you. We can add something in our letter as well. And again, part of this whole intent of the rule is to call out the red flags that, or the sort of red herrings of HIPAA, and call out the things that people have been using, whether with the best intentions or because they just don't want to, or it's not in their business interest, to say that, no, this particular disclosure, this particular kind of sharing isn't permitted. It really, most of them are and should be. And this is the whole point of the rule, is to clarify that. So I think that your comment is well within the realm of what HHS is looking for with respect to comments on this rule and the intent of what it is hoping to achieve.
Thank you. That's great. Catherine, if you want to reach out to me, I'm happy to help with that piece.
Great.
Yeah, no, that's helpful. And I would just add there to what Alice was saying, that, you know, the information blocking rule kind of picks up where HIPAA, well, I shouldn't say it doesn't exactly align, and that's something we're going to talk about in our comment letter as well. But you know, if allowed by HIPAA, it should be also subject to the information blocking rules, which has a set of data that's required to be released from payers and providers. So we should make sure that we highlight that as well for this issue.
Catherine and Alice, it's Adrienne Ellis.
Hi, Adrienne.
So just picking up, I wasn't going to ask the question. I was going to wait till later, but Catherine just mentioned info blocking, and I was a few minutes late to the call. But as for HIPAA right of access, are there exceptions still? So in the info blocking rule, there is a prevention of harm exception, which some of the covered entity healthcare providers are looking into. How is that going to apply? And so I'm curious if that's also continuing to be contemplated in HIPAA, or if that's an area where there is kind of misalignment. Is there a prevention of harm exception to a patient's right of access in HIPAA? Or I think, Catherine, you were just noting the kind of the US CDI, you have to provide that under info blocking, and are you going to try to align HIPAA with that? And so I'm curious if there's still some gray areas in terms of what needs to be provided to patients even from this new HIPAA perspective.
Interesting question. I'm trying to go back into my junior associate brain and picture the place in the privacy rule where it talks about this. You know, we just covered the prevention of harm when it comes to increasing the disclosures when it's for the purpose of preventing harm to happen, or to get out in front of something bad that could happen. But I do think there is something, the provision of access is not just blanket, but I'd have to look at that. And either way, it's a great opportunity to comment on the importance of harmonizing the two sets of rules, the info blocking and what's the other one? Information blocking and interoperability, whichever that other one is, and HIPAA. So we have a whole big section in our letter of all the places that we want there to be better alignment. And this, I'll look into it on the HIPAA front, but certainly add this to the list, either praising the harmonization or clarifying that it should be.
Thank you, Alice.
I see. So we have one question in the chat, but I know, Alice, this is your last slide, so I'll just let you get through this last slide, and then we'll open it up to questions.
Sure. It's been on the screen, and you guys have read it, I assume, so I won't read this word for word. We could have probably filled 3 other slides on additional provisions. There are some clarifying definitions. A definition of an EHR was added. There are a number of sort of more nitty-gritty and technical provisions within the rule, but these are some of the ones that, in talking with our policy steering committee and some of our members, these have been sort of interest and of note. I'll say on the notice of privacy practices front, this is another example of where HHS is trying to ease burdens. In this case, it's really an administrative burden. It seems like a small thing, but the provision of notice of privacy practices and then the written acknowledgement, if you think about all that paperwork and then having to retain copies of the acknowledgement of receipt of the notice of privacy practices for 6 years, that's been actually sort of a hot issue. And this is seen as a really wonderful and conscious step on the part of HHS to understand what providers are dealing with, even in the most sort of ridiculous administrative side when it comes to pieces of paper. there are a couple of other notice of privacy practices specific provisions in the rule. And again, if any of these are places where you want us to follow up or have more specific questions, again, I can't promise that I'll know the answer right now, but this is valuable for us too, to find places where we want to add to our letter or put a finer point on something in our letter. So I will open it up for questions from any of you now.
So the question that we have in the chat, Alice, is regarding the disclosure provisions. Does the proposed rule further define best interest with regard to those experiencing an emergency or crisis?
I don't know, and I will find out.
Yeah, we can follow up on that. I know that in a lot of the cases of those types of broad definitions, like Alice was saying earlier, it is very circumstantial and up to interpretation in a lot of those cases.
Yeah, my guess is no, again, but you know, I can look in the place in the Federal Register where in the preamble where some of these provisions have a little bit more context.
Great. So some of you joined a little bit later, but as you may have picked up, this is a little bit more interactive than some of our webinars. And so we encourage you to turn on your cameras, unmute yourself if you have questions. While you all tee up all of your great questions for Alice, one question I had for you, Alice, is if the rule were finalized, right, as it was proposed right now, do you think that it strikes the right balance between this need that we have for better and more data and the privacy rights of individuals?
I do. I think it becomes an interesting policy question because very often when providers are hesitant to share information with patients, it's because they're worried that the patients don't quite understand the vulnerability of the data. As I was saying earlier, there's a sort of misconception that health data is protected by HIPAA, period. And instead, HIPAA applies to people who hold it. And there's a sort of paternalistic impulse to think that patients can't understand that or can't be educated to understand it. It's an interesting area of law and it's an interesting area of debate. I do think there's an education component to this that's important because while it is beneficial and in some cases probably crucial to have social services organizations and community-based organizations and all members of an individual's care team have easy, not unauthorized, not individually authorized access to information, there may not be the same level of data sophistication in some of these organizations or with some of these care team members that there is within a traditional healthcare system. And so there are always these debates over to whom should that burden fall, the patient education component. And I'm sure many of you on this call spend a lot of time thinking about those issues as well. So very often HHS will put out sub-regulatory guidance, and this might be an area where there's some thinking to be done on how not necessarily to restrict access, but how to make sure that the members or the people who are gaining access to health information that they might not otherwise have had because of HIPAA, because prior to these expansions and relaxations, that there's some concurrent education or informing the people who are taking ownership of the health data, what the protections are. And again, shameless plug for EHI's work on the non-HIPAA covered data universe. It's a real issue. So there's a whole lot of educating to be done. And many of you, again, I'm sure are doing the Lord's work in providing that. Any other questions? Anything you would like? You know, as I said, we're working on this letter. We are almost finished, but if there are any issues that you particularly feel strongly about or you think have been under addressed or under discussed that we can help you by including in our letter, again, even if you can't think of something right now, if you want to follow up with us, again, the comment deadline is May 6th. So like maybe May 6th by 11:59 p.m. was our deadline. But any thoughts you have in the next week or so, we'd be happy to discuss with you and possibly even edit the letter.
There's one question in here in the chat. Does EHI have any expectations that the final rule will differ substantially due to the change in HHS leadership?
That's a great question, and that was discussed so frequently in the month of January when the administration was about to turn over and the rule hadn't been published yet, and everybody was wondering what was going to happen to it. And since then, no, I have not heard anything. As I said, it's a pretty popular rule. I am sure it will change somewhat. It always does based on comments, but I have not had any sense that the new administration is going to go in any sort of a meaningful different direction, and I would be surprised if they did.
I concur.
Oh, good.
Hi, this is
there any
Leslie,
last?
Professor. Can you hear me okay?
Yes. Hi, Leslie.
Yes.
Hi, thank you all for having this today. It was very helpful. I'm just feeling so passionate about these providers and trying to understand. They're already still not really well versed sometimes in HIPAA. Now we've got some changes to some of the HIPAA rules. And then on top of it, we're going to have their patients coming to them and saying, oh, but I want you to send my data around as well with the app of my choice. And it seems like we're always listening to wonderful presentations from OCR or from ONC, and everybody talks about their components, but we need some place to compare and contrast what the real world providers are going to have to do and how different pieces, are really applying to them. Are there any thoughts about EHI or any of our other organizations putting together maybe compare and contrast against the rules? For example, taking the topic of access and just looking across OCR, the way it is now, the way it's proposed under the privacy rules you're talking about, and then the patient access rules and how access to EHI compares and contrasts. Does anybody else think that would be helpful?
Yes.
Yeah, I think it would be helpful, and I think it's right in EHI's wheelhouse to do something like that. I think that's a great idea. I would love to follow up with you after this and talk a little bit more about the format that you think would be most helpful. But I don't want to commit, Catherine, without asking. But I think that's a perfect EHI project, and if it would be helpful to you all, we'd be delighted to start in.
Awesome, thank you.
Yeah, and I think that's a good point, and we're going to try to call out some of those inconsistencies. And actually, we mentioned it also when we met with ONC and Dr. Tripathi, the new ONC coordinator, last week, some of these harmonization issues. Of course, they don't have jurisdiction over this rule, but it's still important to highlight the issues.
That's a great point, Catherine. He was very candid in saying that often they don't even understand where there is harmonization conflict or where the rules may conflict with each other, partly because there is still a little bit of a siloed jurisdiction over which rules and which organizations, but also because they're not in the real world situation where they're understanding what it means to try to comply with 4 different laws that all slightly differ. It may not seem that way from the lawyers and policy perspective, but it really means a lot to all of us and all of you who are dealing with these. So he was very kind in saying, please tell us where the sore spots are, where the tension points are. And again, even if it's not an ONC rule, he seemed very eager to help with that conversation and to sort of push the harmonization goal as far as he could. So that's good news for all of us.
Yeah. Well, with that, we are at 3:30 now. We are at time for the quick and dirty monthly process policy briefings that we do. Wanted to put in a quick plug for next month. We're going to be joined by some folks to discuss the new infrastructure package that's being proposed by President Biden and how broadband infrastructure fits into that, or it will fit into that. So hope you will join us in May for that discussion. And as Alice said, you can always reach out to either of us to discuss our comment letter on the proposed rule, which is due May 6th, or any other thing you want to talk about.
Thank you all. Thanks, Catherine.
Thank you. Have a great afternoon.
Bye.